Thank you, everyone, for tuning in today for our CE series, our clinical conversations. Today, we have Amanda Woods here, and we're talking about a really important topic. We're going to be talking about end-of-life care and the ethics that go along with it. So I'm going to do introductions and housekeeping in just a moment, but I wanted to welcome Amanda. Welcome, Amanda.
Hello.
So let me do some introductions and then we will get into talking about what Amanda does and we'll start our conversation from there. So a little bit about me. I am a child and adolescent therapist with Brain Space Wellness. I work in private practice. Lots of different interests. Also, I run Agents of Change test prep, and now we have moved into the CE space, which we're really excited about. Some of my areas of interest, I have many. I work with children, so play therapy is one of them, expressive arts. And then also I am currently a DSW candidate at SUNY Buffalo. And in that program, I am focused on technology, cultural humility, and clinical supervision. So Amanda, we're just chatting right before this. We always have our hands in a lot of different things and we're doing a lot of different roles at once. So that's just a little bit about me. And let me tell you a little bit about Amanda. So this is Amanda Woods, MSW, licensed independent clinical social worker. And she's been working in medical and behavior health settings for over a decade. She currently serves as a LCSW at Overlake Medical Center and Clinics. She specializes in psychosocial assessments, discharge planning, and behavior health evaluations. She will tell you more about what she does on a day-to-day in just a moment. Before this work, she worked at Evergreen Health, St. Vincent's Medical Center. We talked about this. She's been in medical settings and hospitals for most of her career. She's worked within emergency departments, inpatient units, and long-term care facilities where she conducted individual and family counseling, end-of-life care, complex transitions between medical and behavioral health services. And she has expertise in emotional, financial, and ethical challenges related to patient care. And we're going to talk about this. Obviously, this is her expertise, but she's been dedicated to advocating for patients' rights, ensuring ethical decision-making, specifically with end-of-life care. We're going to get into that today. It can be a very complex and very nuanced transition for people. And she supports both patients and their families through difficult medical decisions while also working through the complexities of our healthcare system here in the US, which can be very complicated in and of itself. So we are very excited to have Amanda here today and for her to share her expertise. So we will get to her in just a moment, but we have to do our housekeeping so you all can get your CEs. Why is this important? Well, end-of-life care is part of life, so it's important that we talk about it. And there's three important things that we're going to touch on and weave into our conversation today. So patient autonomy and rights, right? We know that patients have a right to autonomy and making those decisions are important. So we are going to talk with Amanda about what are some dilemmas that come up, refusing treatment, withdrawing treatment. We're going to talk about DNRs. We're going to talk about advanced directives. So we will touch on that a little bit more. Emotional and ethical complexities for families and caregivers. We know that end-of-life care can be a very, very hard time, not just for the patient, but for their families. So oftentimes we know that this can be very complex. So what are the guidelines when you're working not only with the patient, but you're working with their families as well? And there could be some conflict around the decisions that are made there. And then cultural and social implications. We're going to touch on cultural humility. That definitely plays a role in end-of-life care, people's beliefs, people's value systems, and how can we as mental health providers be culturally sensitive while also being ethically appropriate? So it's a very important topic. And then we have 3 learning objectives today. Participants will be able to analyze ethical dilemmas in end-of-life care. We're going to talk about patient autonomy, informed consent, and we're going to also I'm going to ask Amanda, like, when's a time that you faced a dilemma like that? So we're going to hear from people who have experience in the field. Develop culturally sensitive communication strategies. We are going to talk about cultural humility and how that plays into the work that people do in end-of-life care. And then lastly, participants will be able to demonstrate decision-making skills. I am sure Amanda uses problem-solving and decision-making skills every minute that she is working with patients in the hospital. So we'll talk about that. Interdisciplinary teams, right? We know in hospitals, it's not just social workers or mental health professionals there. So having to work with doctors and different providers and skilled nursing staff. So we will talk about all of those today. But without further ado, I want to pass it on over to Amanda. So Amanda, welcome. And I
Thank
guess
you.
we can start by just tell us a little bit about yourself and the work that you do.
So currently I'm working at Overlake Hospital Medical Center. I'm on medical surgical floor. So I have about 40 patients that I'm assigned to. I don't see all of them every day, but I do need to help with their discharge plan. I do have to help families navigate what's best for their loved one in terms of the disposition plan, as well as talking with the care team and the doctor, nursing staff about where the care and treatment is going and what we need to do to help ensure the safety and well-being of the patient.
Yeah, and I know you've been doing this a long time. How did you get into this work? Tell us a little bit about that journey.
Yeah, so actually when I was doing my MSW program, I was doing an internship, and I thought I would be a school social worker. I actually have a learning disability, so countertransference was an issue for me.
Okay.
So I knew this was not going to be the journey for me as being a school social worker. And I actually questioned if I should be a social worker at any real, I was like, I don't know. What if I'm like struggling with this throughout like everywhere I work? But thankfully, medical social work really just spoke well to me. My mom's a nurse too. So it really worked out perfectly just from the internship experience, the second one that I had in hospital setting, and it worked out very well for me. So
Great. And we went through a little bit of your bio. You've done it all, right? So we know that doing your job in a hospital, it's not just one thing that you do. You do many, many, many different
yes.
things. So before we kind of hop into the questions, just a very brief overview, what is end of life care?
So end of life care is when a patient is very gravely ill. They have anywhere from days, weeks, to even a few months to possibly survive. And then we have to kind of come up with a plan from there in the hospital setting. Will the patient potentially pass away at the hospital? Are they okay enough to maybe be transitioned in a home environment or in a new environment like an assisted living facility or adult family home where they can get the care that they need and the treatment that they need, and also having hospice care services to ensure that they're getting services 2 times a week from a nurse just to check in from hospice and ensuring that they have the comfort measures adhered to.
Okay, perfect. So let's jump in. Our first question is, how do you navigate situations where a patient's end of life care plan or wishes conflict with the desires of their family? I have heard many, many, many stories where this can be really, really, really tricky.
Very tricky. And I actually have an example I'd like to start off with and provide too. So I did have a patient in an intensive care unit who was deemed they had their medical wishes determined as do not resuscitate, do not intubate. So the DNI code status, if you will. And the patient was coded and died while in the intensive care unit, but the daughter stopped everything. She's like, I want the doctor to just, do everything. I can't have mom pass like this. And the doctor decided to go ahead and go against what was in her advanced directive and perform CPR. And this doesn't usually happen, but not only did the patient survive, but also days, weeks later, I was still her social worker for the patient. And she said to me and to all the care team, I'm so grateful to be alive, and I have an opportunity now to go to rehab and gain strength and mobility. Had it not been for my daughter, this wouldn't have happened. And that's a pretty remarkable story that I have to share because, people do these advanced directives thinking that they're a certain code status, and then really maybe it's for the best that this actually happened and had full care because she did get to survive. So advanced directives are always something that can be changed and should always be considered.
And that's good to know because I am just taking notes here. How often should people plan these types of things, advanced directives? And I'm sure it depends on the level of severity, right? Maybe they have more of a long term. So tell us a little bit more about how you have these conversations with people and how often you're having the conversations with people around this.
So I have this conversation often during their hospitalization stay. When they get to my floor, I typically have to say, okay, well, since you are decisional and you can make this decision for yourself, you haven't, let's say, completed the advanced directive. I like to give people and the patients opportunities to then not only appoint who they would want for medical wishes, but what their medical wishes they want to have happen in the hospital. Do you want tube feeds? Do you want antibiotics? Do you want to be intubated? And I want to give these opportunities because and options to them, because I think it's really important for just what they want for themselves and being able to make these decisions. And I think having these conversations early and often is so important, whether it be in your 30s, whether it be in your 50s, it doesn't matter. Illness can strike anyone at any point in time.
This is a side note, I taught a grief across the lifespan class, and we talked about, it was a master's level class, and we talked about how just in society we shy away from these discussions so much because it's uncomfortable. But when you approach them early and often, it makes it's preventative work. So it really does help the process along if you've had these conversations. Like you said, there's no wrong age to begin having these conversations.
Exactly. And then the nice thing about these documentation of advanced directives or PULSE form, the physician orders sustaining life treatment, these are things that are ever changing too. If you decide, I want to be this status, like codes like DNR or DNI, or I want to be full code and get all the treatment that I want, you can change these. These are interchangeable at any point in your life.
Okay. And I know we're throwing out some terms here. Can you I know we've thrown some terms out. Can you just describe what advanced directives are, DNR and DNI are? DNI is.
Yeah, so DNI, so DNR, so do not resuscitate, and then also do not intubate. So that's for people who are, let's say in the intensive care unit, and then we have to make this decision of, do we need to intubate? Is this going to be something where we put like a breathing tube to help them sustain life? And this could be something ongoing needed for the duration of their life. And if they're in their 40s, is it beneficial or is it harmful? Like, these are the conversations that the medical team is having with the families, and ongoing too, of course, while they're in the intensive care unit. And then advanced directives are just really, what are your medical wishes? What do you want for yourself in terms of care and treatment? Do you want the feeding tube? Do you want the intubation, the breathing tube put in place? And would you want that indefinitely, or would you only want that for a short duration of time? Like, we can make these decisions with the patients can make these decisions at any point in their time, but I think it's better to do it while you're alert and oriented than having someone else make that decision for them.
And that was going to be my question. We always want to work from a framework of self-determination, right? But I am guessing in your case, there are situations where the patient is not able to make those decisions. So what happens if the patient is not able, for medical reasons or, cognitive reasons or whatnot, that they're not able to make this? Does it go to whoever is next of kin? How does that work?
Generally, that does happen. Legal next of kin, that is who we would want to then, of course, contact and see what they would. But if the legal next of kin is uncomfortable making this decision, like a parent or a spouse, a child for their loved one, then we may need to also consider what's ethically responsible, having a couple different doctors communicate this together and really say what's in the best interest of the patient, or even potentially having guardianship, which can take a really long time. We try to avoid that as much as possible, but sometimes we do need to pursue that option if it really isn't anyone to make this decision and the doctors are undecided what's in the best interest, because there might be some conflict of interest there from two different physicians.
Yeah. A little bit of a follow-up. How do you, I'm sure you have to do this, but how do you navigate conversations when maybe even within a family, family members aren't on the same page? Maybe there's multiple siblings or there's a partner and adult children. How does those conversations work? Because I could imagine there could be a lot of different feelings one way or the other.
Oh, yes, this definitely has happened. And this is where I also would want to have, of course, ethics committee there, of course, palliative care team as well to help with navigating this as well. So it's a big care conference, kind of a meeting that we all work together on this with the family, of course. And then we try to get the family all to agree on the same care and treatment plan. That's really hard to do, but we try to look at
Yeah.
it from a risks and benefits perspective of what's in the best interest for the patient moving forward. And this will take time. We don't expect to have an answer the same day, but we do keep chipping away at it like almost every day until everyone can kind of agree on what the next plan, of course, is going to be.
So this is a follow-up again. You work on multidisciplinary teams, right? Who
Yes.
in the hospital, when you're doing these end-of-life care planning, discharge planning, who might be some people that are keyed in or having discussions around a client's care?
So that would be obviously the attending physician who's taking care of the patient, bedside nurse. Palliative care may also be stepping into this as
Mhm.
well. They also help navigate the conversation of not only just end of life, but what's comfortable for the patient. What are their wishes? What would they have wanted? Really hearing from families too, even if it is against what the patient may have wanted. At least we can just have everybody be there at the table and having this conversation. Sometimes I do have to rope in and ask ethics committee, especially if there is a potential for a risks and benefits perspective of what is in the best, what medical treatment is going to be best for the patient moving forward.
So hospitals are very different in a lot of situations because you do have an ethics committee. So if you did have to raise a situation to the ethics committee, what would be some information you might present, or what does the ethics committee do? Which is great that hospitals have this.
Yes, it is great that they have this. And what actually, I had an experience too where I worked with ethics committee, and they've actually helped make the decision that escalating a patient's care is actually harmful and should not be explored or not be adhered to during the hospitalization course. And typically who's on that in the ethics committee is a physician. It's psychiatry, it's my social work manager, and a couple other different disciplines that are involved in this committee. But the doctor that's part of this right now, who he kind of drives it more so with this conversation of risks and benefits, harm, and all of that. It's amazing what they can do as a group and to make these determinations.
Oh, that's great. So we're gonna shift gears a little bit to talk about cultural humility, right? We know that there's so many different factors that play into how patients may view end of life culturally, how religiously, spiritually. So how do you have these conversations with clients and their families, and how do you ensure that you're respecting their cultural backgrounds and coming from a place of not being the expert on them in their lives when you're dealing with end of life care?
Yeah, so I've come across many different cultures and religious beliefs, and some of them have this belief that they want to do everything that they can to keep a patient alive. That's pretty much been my experience from different cultural perspectives and religious beliefs. And I don't judge. I do not put any agenda on the family. Of course, I just want to meet the family where they are. I just want to support them best of my ability, listen to their concerns, listen to any questions they have regarding the care and treatment, pass it on to the doctor. I just really want to be a voice for them in a time that's really challenging for them. And even hand holding is really important when they're going through such a challenging time to see their loved one as sick as they are.
And kind of talking a little bit about that, having these discussions, right? Have you ever had any situations where maybe it is in their belief system that they want the opposite, right? Like, I want to be hands off with medical care? And how do you're working in a hospital, it's a medical system. How do you maybe have those conversations as well?
Yeah, so there are some cultural beliefs too. They might say we just want our loved one to pass away and just but basically what they call withdrawal of care and
Okay.
not continue with intubation, not continue with anything with life sustaining measures. Of course, I'm there for them for that decision because that's a very difficult decision to make, and I'm supporting them through that choice. And then, of course, we have the doctors say things like, we want to make sure your loved one is comfortable. We'll give the morphine medication. We'll provide all the services and the care that they need to be well supported through that end of lifetime.
And I know you mentioned earlier, maybe going to a step down facility or assisted living or even hospice. So, how do you have those conversations about if they are leaving the hospital and there is time to plan for that? How do you approach these conversations about discharge and what the next steps are?
Yeah, so I'll tell the family that they have more time than maybe we had thought. Maybe we thought, oh, okay, your loved one could pass in the hospital. A couple weeks go by, we're realizing, well, they're eating, they're doing really well. They're able to maybe they don't have as little time as we thought. So I present that to the family like it's a good thing. Your
Yeah.
loved one's doing well. They might even graduate from hospice eventually, but we do need to think of a plan. And families are actually receptive to that. Yeah, I really want my mom to go to or my dad or my loved one to go to a care facility
Mhm.
because home plan might be hard for us because we're
Yep.
working full time. We can't support our loved one that way. So then I like to be able to present it as, well, I can help facilitate navigating with you the options for assisted living or adult family home and making sure they have the care that they need when they do transition into a care facility.
And those can be really tough conversations too, just from personal experience. Both my grandparents passed while in hospice care. For someone that's new to it, knowing what services are available and what does this mean, and it was all brand new to my family, right? Like you will have people that can come to the home, and but then also what does it mean in the meantime for having care, people helping with basic living needs and whatnot. So there's a lot to consider that I think can be very overwhelming, right? It's like, of course, yes, if possible, I want my family member to come home, but there's a lot of logistical stuff that goes into that, and planning for that and having someone discuss it with them is really important.
Yeah, and even families do wrestle with the idea of, do I hire caregivers? But then we talk about daily caregiver support, and they're like, that's more expensive than
Yeah.
just having them go to an assisted living. I'd rather them just
Yes.
be in an assisted living facility.
And I don't know if you have to deal with this much. Do you have to have conversations about what does your insurance cover and what is not covered, and having discussions about resource wise, what is doable and not doable?
I do have those conversations. Majority of the things like adult family home or assisted living are something they have to pay privately for
Yeah.
facility, and that's very expensive. But when we break down the numbers for caregivers and home versus the placement can be a little bit cheaper, believe it or not, because caregivers daily and hourly it's ridiculous. And
Mm-hmm.
then I also do present when they have Medicaid, you could potentially be in an adult family home paid for through
Yeah.
Medicaid. You don't have to worry about it out of pocket expense. But those kind of patients, unfortunately, it takes such a long time to have this all be started with the state and the caseworkers. It can take months before they're ever really transitioned into an adult family home setting through
And they
Medicaid.
might not have months to be able, they might not have that luxury.
Exactly. Yeah.
It can be, that is something that I hear often, not just for end of life care, but just people working within hospitals or hospital systems or where there's insurance at play. There's a lot of red tape, right? And understanding insurance itself is difficult, right? But then when you're adding in all these different services, what is covered, what is not covered, will I be reimbursed for it? Or how do I submit this? It is very, very, very challenging. And I'm sure you see this, it's an added stressor at a time when people are already under great amounts of stress.
Exactly. Yes.
So we're going to talk about ethics. That's what this is about. we have to, as mental health professionals, always be, ethics should always be driving what we do. But I feel like this work that you do can be, ethics is front of mind probably very often. So what ethical considerations come into play when you are making these decisions with people? And I always tell people ethics is never black and white. There's lots of gray area.
Lots of gray area. And especially if they, again, if the patient comes in without having an advance directive, knowing what their medical wishes are, it just presents even more of a challenge. And then you're not really sure what they would want for care and treatment. But on top of that, who are we going to? Are we going to the legal next of kin? Do they have a power of attorney at least determined? And if not, are we petitioning for guardianship? There's a lot to consider with end of life, and especially if the patient is not alert and oriented and they can't speak for what they would want. It's very challenging.
So, question about this, there's lots of nuances, right? My question is, how do you document this, right? Because it could be fluid, right? Maybe someone is conscious one day and then they quickly deteriorate. So, from your perspective as an end of life clinician and working in this system, what does documentation look like? How do you make sure this is documented? Because we know if it's not documented, it didn't happen. So how does documentation work? How do you keep up with this ever-changing fluid landscape?
Yeah, so my documentation, I always include like what the doctor has indicated to me, what our conversation looks like on almost whatever. I think it's pretty consistent. Like it's mostly daily if it's a case like this. And then of course I'm documenting what the doctor tells me, the nursing team, whether or not from nursing notes as well as from what I'm being told, are they alert and oriented yet? Are they not? Are they medically? How are they doing medically? So I document everything that is told to me, what I'm reading in chart, and of course, what if I do talk to family, what that conversation looks like too. So my notes are pretty detailed. They're pretty lengthy at times, especially for a case this complex.
Yeah, I would imagine. And then do you have any examples of a case where you've had to go to the ethics committee or just like, I don't know what to do here. This is really complicated. Is there anything that, I'm sure this happens a lot, but anything that sticks out in your mind as something that was really, really tricky?
Yes, recently actually too. So we had a patient, or we still have a patient, they're not passed yet, but on hemodialysis, but before hemodialysis was actually on peritoneal dialysis, not doing great with that, obviously. So we transitioned to hemodialysis, didn't go well. He's been at the hospital now for like 135 days. And just kind of seeing, he's not alert and oriented. He has a wife who's power of attorney, but she has been having a hard time answering for what his care wishes would be. She's having a hard time speaking to everything. The children are involved too. And they're just like, I don't know what dad would want. We don't know. This is just really hard to see him like this. So what all came together with palliative care, even with ethics, we kind of decided that because of his agitation during hemodialysis, pulling at the lines, we kind of realized that maybe this isn't beneficial care to have hemodialysis ongoing. And we had to present that to the family. And it did take a few days to have them think it over. And then they did decide to stop the hemodialysis. And now he'll likely just be made comfort care, and then he'll pass away here at the hospital.
Yeah, and these are not easy decisions, right? These are things that in multidisciplinary, it's not just also what we are going by, right? There's medical decisions, there's a lot of different things that are at play with this. So that's really important to know that you might need to escalate it to get different eyes on this and get people that can help. What's really hard, like you said, is sometimes time is of the essence, so there might not be time to have these conversations. So it's always good when time's on our side. But do you ever see that sometimes like it is a matter of you have to make this decision, the doctor would have to make a decision like right in that moment?
So the nice thing, well, at least with Overlake Hospital, other hospitals, yes, I've had the pressure of like, we have to have the family make a decision,
Now.
but I also slow it down. I've told doctors many times, I cannot rush this with the family. We cannot as a group rush this with the family. We need this. This is very sensitive.
Yeah.
And we have patient experience too. So we
Mhm.
have people that look at this from a patient experience perspective. If we harm the family by saying you have to make a decision today, that this is going to be harmful to the hospital overall. And we do look at that too, like,
Mhm.
the ratings of the hospital. So we want to
Right.
make sure that we're doing this correctly and with compassion. I really do believe every life that we touch should be filled with compassion and empathy, and giving it the time that it needs, that the family needs, especially to make these decisions with what the information that we're providing them. I think it's I mean, we can always say we can give it a few more days, a week, but I do think we should give them the time and the space to do that.
I love that you said like coming from a lens of compassion, because I'm just thinking of multidisciplinary teams. I come from a school, so it's very different, but everyone has different ways of viewing things, right? I'm sure doctors are coming from the medical perspective. We are probably coming more from a biopsychosocial approach. So sometimes we need to give our opinion from the mental health space of, I'm just also thinking too, when tensions are really high, we don't want to have people making decisions in a time of like a tremendous amount of pressure and stress that they would maybe regret later on.
Exactly.
Um, Moving into our last question. So hospitals, our medical system, right? There's a lot from a macro perspective, there's a lot of different systems at play here. How does how do you manage working within a larger system where they might have their own policies and procedures, they might not have resources, or you've worked in a couple different places, so it probably actually differs from which setting that you are in, which hospital. You could go down the road and it could be very different. So how does that come into play of working with organizations, right?
Yeah. So, there are very different organizations out there, but I think for hospitals, though, we generally do always have an ethics committee or risk
Mhm.
management, and so that's really, I think, very pivotal in a
Yeah.
hospital setting, because you do have to look at things from a legality perspective too, what's legally and ethically sound when working with patients, especially with end of life. So at least I always know in hospital settings, that is like number one, is like risk management and ethics committee. Those are very essential, and when working with in patients like this.
And then how do you get from a social work perspective? Not everyone works from our code of ethics, right? So how do you always operate from our code of ethics, but also there's policies that you have to adhere to at the hospital level?
Yeah, and I think what's nice of what my role can be too is I really like to slow it down when I am able to. I like to voice that. I like to be able to tell doctors and the team, I know what you're wanting in this moment. You're probably not going to get it. So don't
Yeah.
rush anybody. Don't do more harm with this. So I do like that I can be that voice for the patient, the family, and really slow things down. I have been pressured before to give
Yeah.
this important Medicare message number 2 and tell them they're discharging today. And I said, no, that's not what we're going to do today. We're not going to be giving this to a patient's family when they're still deciding and mulling over what they want for a decision regarding their discharge plan. A decision has not been made yet. So I
Mhm.
can't justify this letter being provided to the patient and the family.
Yeah.
So that's kind of what I've been kind of asked to do before. So,
Yeah. And because they're not operating under the same framework that we are, right?
right.
And that happens a lot. Have there ever been constraints, or not even necessarily constraints, but maybe barriers that prevent you from advocating, or challenges that come up when you're trying to advocate for a patient that you come up against due to the system that you're working in?
Yes, and I would say leadership. Sometimes
Yeah.
leadership asks me to do things that I get I'm like, it's really surprising because it's coming from a director role, a director level. And I'm like, why is my director asking me to do these things when I know it's not ethical, it's not sound? And I will even present it to my manager too, who will
Yeah.
also then talk to the director. But I have to read the emails that I'm receiving from the director and say, that's not what I'm going to do today. I know this, and I'm going to then not just take it up with the director directly. I'm going to take it up to my manager to then have them have the conversation, because there's a lot that leadership doesn't really understand our role as social workers and how to give that compassionate empathy care towards patients and families. They're just looking at the bottom line, the
Yep.
numbers, the financials, and I get it. Patients
Mm-hmm.
staying here longer is going to be
Costly.
expensive and
Yeah.
costly.
It's parallels. It's obviously very different, but working in a school, it was similar. You have this system, like the principal or superintendent is telling you to do one thing, and you're like, hey, like I have to operate this way. So I think that is in any large system that you're coming up against. We also live in a system where money and resources are very important to discuss. And what does that mean? And hospitals have to stay afloat, right? At some point, schools need to stay afloat too. So there's a lot of different barriers that just being in a larger system poses.
For sure. Yes.
So that actually, talking about that, actually I brought was making me think of something. Is there within a hospital, how do you make sure you're staying in your lane, you're staying within your scope of practice? Because we are asked to do things that it's like, you know what, this isn't necessarily in my lane. And we know that ethically we have to be within our scope. We're not legal experts, we're not giving legal advice. So how do you always keep that and think through those situations where you have to really stay in your scope of practice? And we do a lot, but there's a lot that's outside of our scope of practice. We're just not trained to do that. And legally, it can get really fuzzy if we are stepping out of that. So how does the scope of practice and staying within our limitations, how does that come up for you?
Yeah, then it does come up for me too. And that's where, again, I would want to have care conference with a medical team too, and
Yeah.
even maybe rope in my manager as well, and really just discuss this at a greater length and just say, this is what I've done. I think there could be more, but I don't want to overstep anything. I don't want to do anything that's, especially if I have to be asked to see a patient, see family, and bring something up that's not comfortable for me, right? Like end of life stuff that the doctor hasn't even, put the hospice consult in for, and I'm being asked, okay, just have this conversation. No, I don't want to have a conversation if the doctor hasn't had it first. The
Yeah.
hospice
Yeah.
care. So I don't want to, I'm not doing this conversation until I know the doctor's had it first. And I do like to bring in everybody together when, if I am asked to do something that isn't quite up to what I'm comfortable doing. So
I will say that advocate for yourself. Do not do something you don't feel comfortable with, or at least
exactly.
talk to a manager or someone that you can bounce the because I will say, especially I'm very much seasoned at this point, but when I was first starting, it's hard. It's like you don't know how to have these difficult conversations, right? It's like sometimes you feel like you have to do what the orders are, but I will say advocate for yourself. If something's not sitting right with you, listen to that. That's really, really, really important.
Of course. And it's also great to get consultation from, and I hope that this is happening in
Yes.
hospitals, that the manager of social worker or nurse case, that I hope it is a social worker that's
Yeah.
managing this, because then you can really get adequate consultation support from an
And
actual social worker.
you and I have been in the field over a decade. I cannot tell you, I feel like actually the more I've been practicing, the more I realize I don't know. It's important to speak with others and get that consultation. It is never as easy as it seems. Like there's no answer that's like, oh, this was the easiest, decision I've ever made. Like it is tricky because we are talking about human beings and human beings are complex.
Yes, for sure.
So talking about like having these conversations, not working in outside of your scope, how important is communication skills and the role that you have? Communication with other providers, medical professionals, family. I would think that that's probably a number one skill is effective communication.
It's imperative, absolutely. Whether it be even a simple Volt message, we have the Volt system where we text doctors,
Okay.
whether it be even in person, having conversations. I know a lot of doctors first thing in the morning at 8 a.m. when I first get in the door, I already have a lineup of doctors, like 4 or 5 of them ready to talk about their patients with me.
There you
Like,
go.
this is what I'm dealing with. This is what I need help with. I'm like, I'm ready. I'll just give me the room
Yeah.
numbers and I'll make it work.
Yeah.
So it's imperative.
I know that working in a system like that, you have to communicate and you have to really be able to communicate in real time because and you can tell me what what this is like. There's different people, right? Nurses change, shifts change. So it's very imperative that you're communicating, because you might have someone had the night shift and then they switch out. So I'm sure that that's really important, that everyone's on the same page. And maybe a nurse observes something during the night that you need to be briefed on when you get there.
Exactly. And that's, I think what's really great with, I use the Epic charting system. So I actually do put sticky notes in there. It says like for the team as well as for the physician. So I usually put 2 notes in, one for the team to read and then one for the doctor to read too. If it's something for like next day discharge, or, hey, just be sensitive to this when you're talking to the patient or family. This is a really sensitive topic for them. So I like to give people the heads up of certain things. And it's called the Epic sticky note system that we use.
That's great. And we could have a whole conversation about electronic health record
Right.
systems and all of that and HIPAA and whatnot, but that's a conversation for a different time. So you do really heavy work, right? This is emotionally very difficult for patients, their families, and also for you as the care team. How do you maintain boundaries? Because I could imagine you're getting pulled to want to, some families wanting you to let the boundaries down, and you it pulls at your heartstrings, but you got to have those boundaries. So what do boundaries look like in the work that you do? And it's a hard thing to set boundaries and stick with the boundaries, especially when people are very vulnerable at this time. It's a very difficult time for them.
Of course. Yeah. And when families do approach me, I do want to make the time for them. And I usually do, but I may not spend as much as I would when I initially saw them, right? I might just meet them for like a couple of minutes and just say, this is the time I have with you. So just
Mhm.
what are the important things you're asking or wanting of me for right now? Because you have me for about 2 to 3 minutes. So
Okay.
I do this, especially if it's a patient that's been in the hospital for several days or a few days. I like, we've already met before, you know who I am. So
Yeah, especially if you have 40 patients, there's just no possible way. There's only 24 hours in a day and however many hours in a shift. You don't have time, which you would love to spend time with people as long as possible, but just not realistic within the demands that you have.
exactly.
So, say there's a patient and their family's really struggling. Do you provide referrals? How do you get them more support than what you're able to give in the hospital setting? Maybe they are going to need outside counseling, or they're going to need bereavement support, or what is available that you could give to patients, because you can't be their personal therapist as well in the long term, right? There would just not be, that would not be possible. So how do you provide wraparound care? How do you provide resources, all of that type of stuff?
Yeah, so I definitely provide the resources. I provide things like we have a caregiver list I can give if they're wanting more in-home support. I can provide a senior advisor list, which has names and contact information of people to help with finding assisted living facilities that you're paying out of pocket for generally, unless you
Yeah.
have Medicaid. I also like to give resources for mental health and substance abuse treatment. I have a
Mhm.
list of that at work currently that just has it through what's covered by insurance. And I think
Okay.
that's very helpful for patients too, to navigate. This is what you have Aetna insurance. This is what's covered. This is who you can see. And this is the provider. You can just call and, schedule an appointment.
So a lot of case management, a
Yes,
lot of brokering of services, and just letting people know. And even if it's just maybe they're not ready to take that resource now, they might need it down the road, right? I have
exactly.
often seen with end of life, like maybe right away they're not ready to do it, but maybe in a couple months they're like, you know what, I am ready to, or maybe the person passed and they're like, I'm ready now, or I'm handling this much, it's much harder than I thought it was going to be. I think that could be conversations that you have as well.
Yeah, so when I do like a home health referral, I think, okay, they might do well with home health physical therapy a couple times a week for the first week or something, but then they might transition to hospice. So I try to find a home health agency that I know is going to be able to do both, that you can
Yep.
transition easily from a home health system to then say now they're eligible for hospice, and it's the same agency. They don't have to go through another PCP or go through somebody else to get a referral. It's all under that same agency.
And I have to, of course, ask this. How do you maintain balance? How do you maintain self-care? Um, I think like the more I'm in the field, the more it's never gets easier, but I have better strategies now to deal with it than I would have maybe when I was right out fresh into the field. But how do you manage boundaries, your time, your emotional space? Because we know that we think of like these cases don't just, it'd be nice if we could just leave them at the door, but we're human beings too. So we have some emotional stuff that comes up when dealing with this too. So how do you personally make time for work, make time for yourself, and really manage the two?
Right. So I do take work, or I have taken work home with me on a very rare basis. Talk to my husband about it too, which is helpful. Talking to family, talking to a husband about it, and my mom, because she's a nurse too. That does
There you
help.
go.
Talking helps. But I know when I do not stay late at work. I don't go
Yeah.
beyond my 40 hours a week. I don't. I don't like to. And I don't think it's healthy for me because I need to go
Yeah.
home. I need to go for a walk. I need to make dinner. I need to take care of my husband. Like there's things I have to do for me and for my husband that are just that I can't stay till 9 o'clock at night documenting.
Non-negotiables, right?
Non-negotiable. And what I also like to do about documentation, going back to that very quickly, I like to document in real time. I like to see a
Okay.
patient document immediately. And I think that helps figure out my day better. And I'm able to prioritize and figure out how to balance everything really well by doing it all in real time.
I think documentation is like everyone's bane of their existence if you are and it can, I will say it can if you don't get on top of it, it can pile up. And how are you supposed to remember unless you are keeping your own very good notes, like what happened last weekend? If you're seeing 40 people in a week, it's really, really hard. But I would say that can actually reduce stress so much if you have a streamlined documentation system protocol. Because yes, we can do wonderful, wonderful work, clinical work, but if we're behind on documentation, that's a big problem.
Exactly. Yes. And that's why I like to see a patient, document right away. I don't like to see multiple patients and then be like, what did I just, was that for this number, or this room number or that room? And then I get them all mixed up and I'm like, no, I have to do
Right.
everything in real time.
Yeah. And
One thing at a time.
your records could be subpoenaed, right? Like especially in a hospital, I could imagine they're like, we want to have access to this. If there are some things that get into these sticky, or if they're like going that then to legal, I could imagine you got to have that and if you did not document, they're gonna say, hey, we have a big problem here.
Exactly.
So we'll wrap up with one last question that I always like to ask. So say someone, I think that this work is super, super important. And I mean, there are some programs that very little touch on it. There's other programs in mental health that maybe explore it for a whole semester, or you can get certificates in end of life care and whatnot. If someone is interested in end of life care and hospital social work, or even hospice, right? There's many ways that end of life care can look. You could even be in pediatrics and have to deal with this too, right? What are a few pieces of advice you would give to someone, and lessons you have learned along the way?
Yeah, thank you. So the lessons I've learned along the way in terms of hospice and end of life is just really, I always like to be there for the patient, for the family, even if it's against what the patient would have wanted. The family really still matters too, where they are with their grief, with their seeing their loved one the way that they are, and how hard this is for them. I just want to be where I feel like just being in the moment with the individual or the group of family. I just really want to be there as a support, just knowing that they're not alone in this.
And there's so many things out there. Grief's not linear, right? We learn there's these stages of grief, but it's different for everyone. I'm sure you see this too, that everyone responds differently, and at different increments, right? Like maybe for some people it looks different. So I think that's really important. And I'm sure throughout the years you have seen everyone grieves in a different way.
They do, absolutely. And they're even though they're saying they want to keep their loved one alive, and even though they're saying, okay, he looks good, I'm happy with even if he's not alert and oriented, or she's not alert and oriented, at least I feel that, the family's still having a hard time with it. They're still not seeing their loved one the way that they were before, beforehand. And so it's very hard for them to see their 20 something or 40, 50, 60, whatever age they are,
Yeah.
to see them like that. It's very challenging that are they ever going to get back to where they were? They've asked me that before. And I'm like, I'm not so sure, we're doing the
Yeah.
things you're asking, but I'm not sure if they're going to have the same quality of life that they once had prior to this.
And that is very difficult, right? To accept that. So my piece of advice, and this is, I don't work with end of life care. Obviously, it has weaves into the work that I do, but have those discussions. My last question for you is, you gave great advice, and thank you so much for your expertise. For people that feel like this is taboo, I don't want to talk about end of life, I don't want to talk about death, what advice would you give? Because there really are essential conversations. And just because we feel uncomfortable and don't want to have the conversations, don't mean they don't need to be had. So, what advice would you give to those that, as a society, we know it's not really talked about that much?
We know, yeah. And it's also, I think, that whole thing about not being comfortable with it,
Yeah,
right?
it's
Not even
very
a
uncomfortable.
yeah, even the primary care doctor I see, they haven't even, I'm like, when are they going to ask me about my advance directive or my post form? Like, no one's coming.
You're going to be bringing it up to them. Yeah.
Exactly. I'll be the one asking for my own, forms to be filled. But I know there's resistance to it. But I always tell patients, like, hey, I'm going to give you an advance directive. I'm going to give you this medical wish list for just to have it as a resource. Fill it out when you can. When you go to your primary care doctor, just talk about it. You don't have to necessarily fill it out with a primary care, but just at least have the initial conversation and just think about what it is that I'm presenting to you. This is a really great resource, and I really hope that you take this under advisement, because right now you can make these decisions and you should be able to appoint who you want to adhere to your medical wishes. You should be able to appoint or be able to, direct the care and level of care that you want when you come back to the hospital. So it gives them that kind of, I think it eases the anxiety a little bit when you have the option to make your own choices about what you want for care and treatment in hospital setting or any setting for that matter.
And know that you have the option, because if you don't talk about it, people don't know.
Right.
Yeah. Well, Amanda, thank you so much for sharing your expertise with us. I have left some key resources here with some end of life care. If people are into the research that goes, there's lots of systematic reviews and lots of different resources here about hospice, palliative care, end of life measures, lots of stuff. If people want to check out where some of the stuff came from, always check out the Code of Ethics, because that's just a must read, right? But here's some key resources people can look for if they're looking for a little bit more of the research-based literature here. And of course, Amanda, I just want to thank you today. Such a good, fruitful conversation, and you really are the expert in this. So I thank you for taking the time to share your expertise and talk about this really, really, really important topic.
Thank you. I appreciate this, Megan. Thank you.
Yes, and for those that are watching, to get your CEUs, you will have to fill out your evaluation in your post-test form. So make sure you are doing that if you are trying to get your CEs. But once again, thank you. And thank you to Amanda for sharing her expertise. Thank you, everyone.
Thank you.
I hope you enjoyed this continuing education course from Agents of Change. Want to earn your CE credits for this course? Visit agentsofchangetraining.com or the link in the description to purchase the course and take the post-test. If you're looking for more CEs, check out our unlimited plan. You will get unlimited access to 150 plus ASWB and NBCC approved continuing education courses for one low annual fee. We're always adding new courses. Did I mention we also have 5 free CE credits available too? Check it out at agentsofchangetraining.com.